So I'll be starting off the talk on menopause. So I'm just going to go through what menopause is and the signs and symptoms. So the technical definition of menopause is essentially it starts when you have your final period. It's essentially a retrospective diagnosis, which means that from your last period to 12 months after, that's how we clinically diagnose menopause. Unfortunately, there's no hormonal ways or anything like that to diagnose it. The average age of menopause in Australia is 51 years, but it can happen anywhere from 45 to 55 years. And leading up to menopause, the most common sort of signs that women will report is that their periods would either become irregular, heavier, shorter, or longer in length. What happened? There we go. Didn't come up before. So most women, around 80%, that experience menopausal symptoms won't actually require any medical treatment. However, 25% of women usually will have quite severe or prolonged symptoms that will require medical management. Approximately 400,000 women are having severe menopausal symptoms, but only 1/8, which is not a lot of women, are actually seeking help to be treated. As it states, it remains quite a undertreated condition. So the common signs and symptoms which women may report or experience include irregular periods, which is usually one of the first signs. And as mentioned previously, the periods will either be more or less frequent. And as we approach closer to menopause, the periods become less often, while other symptoms become more prominent, and these can include the really common ones: hot flushes, night sweats. They may experience vaginal dryness or pain during intercourse due to vaginal dryness, also some itching. They may have some urinary symptoms like some incontinence, increased risk of urinary tract infections, or frequency and urgency. Other common symptoms include trouble sleeping, muscle aches and pains, and a lot of women don't know about this. It's mood changes as well, which I'll go into a little bit later. The hot flushes and night sweats most commonly, as mentioned, is one of the most common symptoms that women experience. And they can describe it like a warm or a hot feeling, which usually starts centrally and then spreads over the face, neck and chest. It might last up to a few seconds to a few minutes, and the women may experience this up to 5 years, but for some it may persist up to 10 years or more. Most arise spontaneously. However, alcohol, caffeine and hot drinks are also known to be common triggers. And these hot flushes, if you ask a lot of women, can unfortunately interfere with their sleep. It can cause tiredness and also forgetfulness. The muscle joint aches and pains are usually due to a loss of estrogen, which happens as women progress through menopause, and this is quite a common symptom. Vaginal dryness and urinary symptoms once again happen due to reduction in estrogen. This is one of my friends told me this analogy when I was doing obstetrics and gynae is, if you essentially imagine a grape, which represents a woman who's got normal periods, and after menopause, if you imagine a raisin, that's sort of the analogy she uses to describe to patients, because you have the loss of the moisture, firmness and the elasticity, and hence that's one of the reasons why women can have an increased risk of urinary tract infections, is because the urethra, which is where the urine comes out from the bladder, becomes quite thin. In addition, it contributes to the pain during intercourse, and also increase urinary frequency in the UTIs, as we mentioned. The psychological changes that can happen are reported due to low levels of estrogen is also associated with serotonin, which we know as the happy hormone. And serotonin helps to regulate our moods, emotions and sleep. And low estrogen level has been shown to correlate with lower levels of serotonin. As a result, some women may experience mood changes, anxiety, irritability, forgetfulness, and difficulty making decisions. This is quite a common, but unfortunately not a lot of women talk to their doctors about this. Sexual feelings or the desire to have sex can be a very common thing that will change around menopause, and this is very normal. And a lot of this can be due to their mood symptoms, but also the physical symptoms of vaginal dryness and hot flushes. Whenever a patient will come and talk about their menopausal symptoms, I always make the effort to ask about their desires for sex or if they are having any concerns regarding that, because for a lot of women it's very important and also as part of the relationship. So I always encourage them to talk to their partner, friends, and the doctor. I will now hand over to Dr. Shika. Sorry, is this a question? Yes.
No, I was very simple. Can we get the TV turned up?
TV turned up, I'll get it. Good idea, thank you.
Hi everyone, I'm Rehan. Okay, so I will be talking tonight about hormone replacement therapy. So hormone replacement therapy is simply replacing this estrogen hormone which is lacking during the menopause, responsible for the symptoms. If the patient has got the uterus intact, we need to add the progestogen to it as well. And the reason is that we need to protect the lining of the uterus from the getting thicker and possibly getting malignant over the course of the treatment or over years. So if the patient hasn't got a hysterectomy done, they need to have a combination of the estrogen and progesterone. There is other type of HRT as well. I briefly mentioned them at the end of the slides, but the most common type of the HRT that we use in practice is either just estrogen or the combination of estrogen and progesterone. Who needs HRT? Simply anyone having symptoms of menopause affecting their lifestyle, so they really would benefit from a HRT treatment. Especially if the lifestyle measures fail and still they suffer from the symptoms. I believe Shika is going to talk more about the alternative lifestyle management of the symptoms, but if the symptoms are significant affecting people, then it can be addressed by HRT. And HRT is shown to be the most effective way of controlling the symptoms. It comes in different types, so it can be different types like, I'm not sure Shika, sorry guys, I don't get the second part of my slides.
I have to go forward and come back because that
Right. I might just say it from memory. So it comes in different type HRT. So it can be a patch, it can be a gel, it can be a tablet or a capsule. For vaginal estrogen, it can be like a tablet or pessary or cream. And also for the progestogen B tablet, we sometimes use Marina, which is an intrauterine device. So and we use a combination of them. So it depends on what are the symptoms, what we are trying to address, and what is the best for patient. We might just combine a patch with a tablet or a gel with a tablet, or we just simply use a tablet having both agents in it, or we might just put Marina in and get a patch or gel on top of that. So a combination of the HRT is quite common to use. What we do before starting the HRT, obviously a really detailed medical history needs to be taken. We would like to know if there is any risk factor of heart disease, high blood pressure, diabetes, high cholesterol, if there is history of trouble with breast or any other type of cancer, the ones that they are hormone dependent cancer really. Family history is really important, especially family history of having clots in the leg or chest, family history of breast cancer. These are the things that needs to be assessed, really in detail before deciding about whether a patient is suitable for the HRT or not, and whether what type would be the safest for the patient. And obviously, what's the smoking status? Higher risk for smokers. What's the, BMI like? Examination of the breast, making sure the patients are up to date with the mammogram, pap smears, and we might elect doing a blood test as well if there is no recent one to check for prediabetes, check for cholesterol, and making sure what is underlying possible risk on the track. And after that, we look into different possible factors affecting the risk. As I mentioned, HRT is safe to be used in healthy women between the age of 50 to 60s in general. Really low risk if it started in healthy population between the age of 50 or 60s. Sometimes we use it under the 50s if they have premature or early menopause, but after the age of 60, the risk profile increases as well. And so age of patient is really important. Type of HRT is really affecting the risk profile as well. Transdermal HRT, gels, patches, less systemic absorption, less side effects. And the dose of the HRT, they come in varying strengths. So obviously we start with the lower dose, we try to build up until we can control the symptoms. So the type and dose of the HRT that we use is really important in possibly, predicting the risk of treatment as well. As I mentioned, family history and personal history really important as well. And I think it's the most common question that we get: is HRT safe? Simple answer would be simple and short. Yes, it is safe if used within the 10 years of final period, age under 60. Healthy population, okay? And then if there is underlying medical conditions, need to be looked at separately and assess the risk and benefit. It's more about seeing if the benefit of the HRT outweighs the risk of HRT. So, and there's lots of factors to consider, but generally safe and acceptable and most effective type of treatment. What side effects you might expect from HRT? Nausea, a bit of fluid retention. Some people, they get bleeding, spotting, part of the treatment as a side effect. Sore breast is another possible side effect. Majority of these minor side effects, they settle within the 3 months of the treatment. There are more significant side effects as well. Obviously, blood clots might be a possible side effect of HRT. Transdermal treatments like patch or gel, they have really minimal or no increased risk of clot. When we get to tablets to treat the HRT, there is increased risk, but it's really one case extra in 1,000 patients. So it's a small risk, but there is a risk. The other concern is breast cancer. I think it's one of the biggest concerns, especially in general population. Is it a risk of breast cancer with the HRT? Well, unfortunately, 1 out of 8 women in community, they might suffer from breast cancer at some stage of their life. The increased risk of breast cancer in patients with no significant family history or no personal history is small, but it's not zero. What can affect the risk is really the duration of the treatment. Longer duration of the treatment, more risk of breast cancer. There are some studies suggesting that the type of the progestogen that we use in female with the uterus, that can be a factor as well in terms of risk of breast cancer. Some of them considered to be a bit safer. But obviously anyone with a family history of breast cancer, that would need to be assessed by a specialist to be considered whether it's really safe option or not. Okay. And safety facts, which we go back and it comes back. So safety facts, it doesn't really cause weight gain. It causes a bit of retention, but it's not weight gain. It's more like a fluid retention might happen. Heart disease and a stroke. There is not a significant increased risk of heart disease or stroke for women under the age of 60. this side effect we more see that if we use or past the 60s and then we continue using the HRT. So for healthy patients under the age of 60, it's not a significant risk factor. And so contraindication, or who should be considered to assess the benefit of HRT more in detail. Sometimes we need to decide not to use HRT, use other options, or sometimes we need a specialist review about that. And that's mainly include patients above the age of 60. We tend not to start the HRT above the age of 60 or 10 years after last period. If they have really poor controlled high blood pressure, they might not be a good candidate, or then even if they are a candidate, some forms like transdermal patches or gels are safer considered comparing to the tablets. If they have history of breast or endometrial cancer, they might not be a good candidate, or the ones with a heart disease, a stroke, or clots in the leg or chest. And patients with significant liver disease and gallbladder disease as well, we might need a specialist review about the starting and maybe having a discussion what would be the safest way of treating them with a HRT. And another type of HRT, which is not estrogen or estrogen and progestogen, is called Tibolone. Tibolone is a synthetic steroid and acts as estrogen, progesterone, and testosterone. It helps with the symptoms, not as effective as combined estrogen and progesterone HRT though. It improves libido, and it helps with the osteoporosis or bone density as well. It doesn't really increase the risk of clot or heart disease or stroke in young patients under the age of 60. The risk of breast cancer, it's a concern. I was looking to there's different data on that. I was just checking the Cancer Council statement, and they believe that most of the study supporting that Tibolone risk of breast cancer is more than estrogen only treatments, but less than combined estrogen and progesterone. So it's sitting in between really, okay, but it's not zero. And the other one is a newer medication, Verve. This one is a combination of estrogen and a selective estrogen receptor modulator. It works really interestingly because some part of the body work as estrogen, some part work as an anti-estrogen. Improves symptoms, definitely help with the bone density as well. Limitation is that this medication has interaction with other medications, so it depends on what other medication the patient is on. There's a bit of unclear data about the risk of the breast cancer, heart disease, and stroke on this medication. It's an alternative to the combined hormone replacement therapy, and it's usually, I personally seek opinion from a specialist on that. It's not the first line that I would prescribe, but it's an alternative option, definitely.
Why would you choose this compared to the other ones?
What
would be the reason to go for that?
Well, there are some patients that they might have absolute contraindication to the other forms or not tolerating them. So some patients suffer from the side effect of the HRT to the degree that they can't tolerate it. So that's an alternative, but it's not the commonest. I'm not sure, guys, have you got any patients on that? I personally don't have any patient on it. And as I said, there's really limited data on it. Maybe in future, but it's an option. Yeah. And so and last question, which is common again, how long we need to take HRT? HRT is definitely when we start patient on HRT, 6 to 8 weeks after, we just check and make sure how is the tolerance, what's the side effect, things going well or not, symptoms getting better or not. And then if everything going well, we usually tend to review the HRT 6 to 12 monthly. We need to assess the risk and benefit at least once a year, because the comorbidity might change. The blood pressure might change, the cholesterol level might change, patient might develop diabetes or heart disease. So we have to assess the risk and benefit really early to see, make sure the risk is still less than the benefit. And then obviously less duration, safer in terms of some of the side effects. So it's just a matter of ongoing assessment when patients are on HRT. When patients get to the age of 60, I think that would be the stage that we really need to consider, is it worth pushing the HRT, or shall we just look to other options for treatment of the symptoms? Because some of the symptoms might last longer than that period. But generally, it's just an ongoing assessment. There is no absolute safe period of time. It's not like I can say the first 3 years is absolutely safe. No, it's just a matter of what are the symptoms, how long the patient need it, and how long it's safe to use it. So it's really a dynamic sort of decision. And I think that would be all my slides. Any questions?
Yeah, I've got a few.
Yeah,
But I've already been on HRT, so I actually rang up to make an appointment to see a doctor, and they suggested to come and see at 7 or so.
Okay.
Bring my questions with me. Number one is how dangerous is spotting? Because that's what I'm experiencing for the first time. I've sort of played around with my HRT. When I first started, I just did the regular one. I've got the gel, estrogen, and a tablet as the progesterone, the combo, the pack that comes
Estrogen
together.
combo,
Yeah. Just put it here. Which is not the original I went to. Estrogen Pro.
Yes, yeah.
So originally I went to Angelique. Have you heard of Angelique? It's a tablet that combines both.
Both of them, yeah.
I did that for 2 months and I didn't find a lot of relief with my symptoms. So I went on to that one, which straight away helped me a lot more. So I did the 2 pumps and the progesterone originally, and then I started having a lot of severe pains down there, like period pains or cramping and all that. So I sort of self-diagnosed but I'll just try going down on my estrogen, because I was sort of researching it, was sort of leading to saying that it was too much estrogen. So I dropped it to half a dose, which was just the 1 pump. And that was alright, the pain sort of subsided, but my symptoms were starting to come back, so I thought, I think I better go back to the full dose now. So I went back to the double dose, and that's when I started experiencing, it's like mild period pains and sort of mild bleeding, not even bleeding, it's just not being discharged. And my issue is I'm leaving in less than 2 weeks' time for a 2-month overseas trip, so I'm sort of a little bit panicky. I don't know, I'm sort of thinking I haven't done any checks or anything. And I went to my normal doctor and she did a test and my estrogen was 480 something, if that means anything to you.
Well, you're using the gel, right?
Yes.
Yeah.
So I'm not sure if I'm high on estrogen or if I need more progesterone. Just from my own research, it was saying if you're bleeding, you probably need more progesterone to stop the thickening of the lining and creates the bleeding. So and I want to know how dangerous it is. Should I really go and do some proper checks or?
So I just keep it a bit general for tonight, but it definitely needs to be looked at. It is a side effect of the HRT, yes, but there might be other underlying causes as well. So it definitely needs to be looked at. At least having an ultrasound or something like that is necessary, just to make sure there's no other reasons for the spotting. And if we get to the conclusion that's a side effect of the HRT, no other reason is causing the trouble, then it's talking about the type of the HRT and which one has got less likelihood of giving you spotting. Yes, in general, progesterone is the part that stabilizes the lining of the uterus and reduce the risk of spotting. But the type of the progesterone are a bit different, okay? And sometimes Mirena might be an option. which gives you more stability of the lining. So it really depends. You have to go through making sure there's no other reason, and if it's also HRT, then trying different type of HRT, trying to address that side effect.
Okay.
Yeah.
That's good. Thank you. And the other question was, do supplements affect HRT in any way? Like,
What sort of supplements are you referring
like
to?
supplements like maybe like a multivitamin or omega-3s,
Yeah.
vitamin D, or
The
like just in
general
general.
ones, no, shouldn't affecting the HRT, but there are some natural treatments for the menopause that Shri is going to talk about them. They are over the counters. They are not supplements. They are more natural therapies for menopause symptoms. They are different, obviously, but general vitamin D, Centrum, this sort of stuff
Yeah.
shouldn't affect the HRT.
That's really good.
Right.
Yeah, and you know how you mentioned joint pains and muscle pain? I actually experienced that after I went on a HRT. I never had it before. That was one symptom that I didn't have, but I actually experienced some really severe pains afterwards. Could that cause?
It's not one of the commonest side effects, correct me if I'm wrong, because lack of the estrogen is causing the joint
Yes.
pain, and you're replacing that with the HRT. So we expect the improvement in those symptoms. It's not definitely one of the commonest side effects, no.
So it could be related to something.
Or coincidence, or yeah.
Okay, thank you.
That's all right. Any other questions, guys? Yeah. Thank you. So I hand over to Sheikha.
Yeah. Let's not start. Great. Okay, so in order to cover all facets, we're also talking about non-hormonal treatments, even though, disclaimer, they're less effective than what we've just heard about. So I just wanted to touch on why we want to see you when you're around 50 and why it's good to come in even if you don't think that you're sick. Because it's a good opportunity in your life for us to do some preventative health. Oh, can you hear me okay? Yeah, sorry, I have a mic. Try and speak up. So, yes, 50 is a good age for you to come in and have a general health checkup. So we encourage that, and I'll go into it in a bit more detail. And then we'll just cover some non-hormonal treatment, so medication you can take that's not hormonal based for both the hot flushes and also some of the genital and urinary symptoms. And I'll just run through some of the complementary therapies that you may have heard about and which ones to proceed with caution with and which ones might be worth trying. So anyone that comes in around the age of 50 for a health checkup, it's a good opportunity to explore menopausal symptoms. A lot of women go through huge changes at this time, as we've heard, and might not necessarily think that it's related or might not connect the dots, because menopause is more than just having hot flushes. And so often I get women to fill out a symptom sheet with all of the menopausal symptoms, and usually the same thing happens. They look at the sheet and go, oh, I didn't know this was caused by menopause, etc. So it's a good opportunity to explore that. And then we also at 50 or at any time, but particularly around 50, want to optimise people's heart disease risks. So making sure you've had your blood pressure checked, making sure we've checked your cholesterol and screened your risk for diabetes. And Shika will talk to lifestyle shortly, but making sure we're not drinking too much alcohol, stopping smoking and helping with that if we need to, and making sure that we're exercising for our heart health and our mental health and our bones.
osteoporosis is something we often think about when people are 70 or 80 and they break their hips, but actually we'd rather talk about it much earlier. Some women have medical conditions that affect their bone density or family history that can affect it. Unfortunately, Medicare doesn't pay for everyone to have their bone density checked until they get to 70 unless you have a risk factor that's covered. But that doesn't mean you can't choose to have your own bone density checked if you want to. And then cancer screening, so from 50, every 2 years, we want you to have a mammogram. We have the bowel cancer screening, cervical screening, which is now every 5 years. We can check that's up to date, and skin checks, which we can do here as well. We don't want to forget about skin cancers. And it's not on the schedule, but 50 is a good time to consider having a tetanus and whooping cough booster if you haven't had one. And there's actually, Medicare has health assessments, which I believe we're still doing. Yeah. So anyone who's aged 45 to 49 who has a risk factor for developing chronic disease is eligible to come in and have a health assessment, which involves booking in a long appointment with the nurse, with the GP, and we go through all of your risk factors and see how we can optimise your health outcomes. And the benefit of that is it's also got bill, which is nice for some people. So hormone therapy, so nothing that you can take for menopause is as effective as hormone therapy, which you can think of as essentially it's a condition of estrogen deficiency. The ovaries are no longer producing estrogen, and all of the symptoms that occur at menopause are a direct result of that. So replacing estrogen, as we've heard, is the most effective way to improve the symptoms. But we can't forget about the other benefits on your long-term health. So we know women before menopause have lower risks of things like heart attacks compared to men of the same age because they're protected by their estrogen. And then after menopause, you get that rapid loss in your bone density, you get more osteoporosis, and you get higher rates of heart attacks, more akin to men because you're no longer protected from having that estrogen. And so we know that by going on HRT, that as well as managing the symptoms, you're also going to have reduced risks of heart disease, better bone density, reduced risks of dementia. So there's lots of long-term benefits that you're not going to get by the medications that I'm going to talk about now. This is just the sheet that you may have seen if you've come to see me before. Okay, so why would you then bother with non-hormonal treatments? So, as Rehan said, not everyone can take hormone therapy, and we've already heard about the reasons why we'd be a bit more cautious. That's not to say there might not be something that's suitable for you, but from a GP perspective, it gets a bit more complicated, and we might say this needs a more detailed discussion with a gynecologist or an endocrinologist, and we might refer you on. There's also women who might feel hesitant to take hormones. I know a lot of women I've suggested it to have said, oh no, I would never take those, they're too dangerous. And I'm sure, has everyone heard sort of misconceptions and fears around using hormones? Yeah. So hormone therapy prior to 2000, the year 2000 was extremely popular, and then there was a study that came out that I guess kind of misrepresented the risks of HRT, and then overnight people stopped taking their medications, people stopped selling it, there was lawsuits with pharmaceutical companies, doctors were too scared to prescribe it, and then you've got 20 years of trying to catch up where you've got generations of women that have missed out on good treatments and generations of doctors that never got taught about hormone therapy. So I know a lot of patients have said, you know, I've had patients come in to see me and say, do you prescribe hormones? Because my last doctor said they don't prescribe hormones. So lots of people are either scared of it or they just don't know because it's really complex. And I mean, we're always learning and there's a lot to know. And you know, I learned so many more things just putting this presentation together. So it's more of an art than a science, trying to get the right treatments, which is why we do what we can, but then obviously there are menopause experts that might need to step in if things are a bit more complex. So, having said that, for the hot flushes, there's lots of things you can do that are more behavioural or lifestyle, which Shika will talk about, so I won't go through that list. You can take medications to reduce hot flushes. They won't help with the other symptoms of menopause, but they will usually help reduce the hot flushes by about 60%. And generally we use them off-label, which means they're not medications that were designed for hot flushes or approved for that purpose, but that is a benefit of the medication that we have found over time. And usually by using these medications in a low dose for about 4 weeks should be long enough to know if they're going to help you or not, and after that there's no point persisting. And for all of these medications, if we do try them, we never want you to stop them suddenly, and we want to taper them off if they're not providing benefit. So some of the groups of medications that we can try for hot flushes include a couple of groups of antidepressants. So SSRIs and SNRIs are two different types of antidepressants. We use them generally in lower doses than what we use for depression and anxiety, but the benefit is, as well as hot flushes, if you're having some mood changes and having trouble sleep, then you may benefit in those domains as well. We can also use a medication called gabapentin or pregabalin, which are traditionally seizure medications, and we often use pregabalin or Lyrica as a nerve pain medication, but it can also help with hot flushes. Clonidine is actually approved for hot flushes. It's not used that often, it's traditionally a blood pressure tablet, but it can have some effect in this space as well. And then oxybutynin is a tablet that we traditionally use for overactive bladder, which I didn't know could help with hot flushes until I wrote this presentation yesterday, but apparently it can have some benefit, which is useful if you're also suffering from an overactive bladder at the same time. And then we also have complementary therapy. So these are things that you may see online at the pharmacist, you don't need a script for. Some of them can help, but none of them are as effective as taking estrogen. And the problem with complementary therapies is they don't go through the same vigorous testing that other medicines do. So they don't have to be proven to have an effect, and they don't have to be proven to be safe either. So some of them will have side effects and safety issues, or they may interact with other medications that you're on. So you've just got to be careful. Being natural doesn't necessarily mean that it's safe and effective. The other issue is a lot of the complementary therapies are things that they're not new products, they're things that have been around for a long time. So there's no money to be made by the pharmaceutical companies to do trials, to test these medications against other things, because they're not going to make money from that. So we don't have great data over the long term. But I guess not having great data doesn't mean that something doesn't work. So for a lot of times it's really a matter of trying it for yourself. So the other issue to think of is some of the studies we do have that show benefit for these products do look like they help, but the studies weren't long enough to overcome the effect of placebo. So we know that up to 3 months, any benefit that you get from these medications could just be a placebo, and there's nothing wrong with that. If you feel better, you feel better, but beyond that, you may not get any benefit. Some of the ones you may have heard of would be black cohosh and red clover. Has everyone heard of that? I did have pictures of the products, but I think we're not allowed to say brand names. So they're the main two that you probably would have heard of. So black cohosh is a complementary medicine that comes from a North American plant, and it's supposed to help with hot flushes, but it can cause some stomach upset and it can interact with other medications. And we don't have great evidence that it works beyond placebo effect. Having said that, people do try it. It's a popular complementary therapy. We were out, as a doctor, our main concerns were the risks that it can have on your liver. So previously we thought that it could cause a lot of liver toxicity, though that hasn't been reproduced in larger studies, so we're sort of moving a bit away from that now, and it looks to be safer than we previously thought. And then red clover extract is a type of phytoestrogen, so it's got a chemical in it that has some estrogenic effects in the body. And it's thought to reduce hot flushes by 1 per day, so it's a small effect. But it can be an issue in a woman who's had a history of breast cancer, so that's something to consider. And then soy isoflavones, I think you're talking about soy products.
I'm talking about in food, not in supplements.
Yeah, so that can help, but depends on, not everyone will be able to convert the compound into an active form in the gut. It depends on what bacteria you have, so it's not going to help everyone. Then these are some other interesting things that I've come across. So wild yam cream, limited data. Evening primrose oil, also no benefit has been shown. Flaxseed and ginseng, no better than placebo. Ginseng can actually interact with a lot of medication, so that if you're ever going to try that, it needs to be discussed with your pharmacist to make sure it's not going to be a problem. And then maca also has insufficient evidence. So the only two that I found that look maybe promising is sage leaf and pine bark, which have some limited studies saying that they might have an effect, but we need more information. But if you look up, I mean, there are lots of companies online that create hormone pills for women, and they might have a combination of all of these products in them. So I guess the message is, it's okay to try these things as long as they're not going to harm you. At the end of the day, it's not going to be as effective as hormone therapies, but it's probably going to be more effective than taking nothing. It just depends on what your risk profile is. Has anyone heard about compounded bioidentical hormones? So this is something we don't recommend. It's not something that we would prescribe. They're basically hormones that are said to be tailored and made for you based on salivary tests, working out your hormone levels and compounding a concoction of hormones that's specific to you. It's not regulated and it's not considered to be subject to rigorous safety testing. It's really expensive, and it's no more natural or no better than the hormones that we prescribe. So the advice from the peak menopause bodies is to avoid bioidentical hormones that are compounded. So urogenital symptoms, so we've heard a bit about that from Ishani before. So hot flushes everyone talks about, knows about, but all of the urogenital symptoms people don't talk about. And it's severely undertreated with what women will put up with. And whereas the hot flushes might last for a few years and then pass, the vaginal dryness and the urinary issues can persist and get worse. And they're better off treated early before you get the atrophy of the tissues. So if you can do something about those symptoms early on, then it's going to be better in the long run. And you can take HRT tablets or creams as well as using a vaginal estrogen, and sometimes the combination is more effective. Other things that you might try if you don't want to take medication would be, so sleep is really crucial, using lubricants and moisturizers, avoiding irritants, increasing exercise to increase the blood flow to the tissues, and then just optimizing your general health, reviewing your medications, because we know some medications can affect libido as well, and then pelvic floor strengthening, managing your stress. So that's more for the dryness and the libido. And then for bladder and urinary tract, recommendations are if you're overweight, losing weight will help. Constipation needs to be managed. Reducing things like caffeine and soft drinks. Retraining your bladder, and pelvic floor physios. I can't encourage people to see them enough. They're really good at what they do, and I think that every woman can benefit from seeing a pelvic floor physio. You don't have to be 70, incontinent, or have a prolapse. There's something everyone can learn from seeing a pelvic floor expert. So then in terms of medications, so we can use medications that will help with an overactive bladder or incontinence. And then some women, especially if you've had kids, may have some prolapse, which is going to contribute to problems as well. And I've had a few that say, well, I don't want to do anything about it, and that's fine, but at least we want people to feel comfortable to be able to talk about these things, because it can be embarrassing if you've got lumps where there shouldn't be, or where there's accidents, and it's quite common in stress incontinence, when you laugh or sneeze or something and a bit of wee comes out, very common. And we just want more people to feel comfortable to be able to talk about these things and not have to suffer in silence. So that's it. Any questions?
Great time, everyone's still awake. Got a bit of juice left.
So if any of you have ever spoken to me, you'll know I love talking about lifestyle medicine and anything that we can use with our lifestyles, not necessarily instead of other treatments that we have that we know are effective, but the good thing is that you can do all these things with the other treatments. So if any of these little tweaks help you to need a lower dose of HRT, or need it for less time, or just help you to feel better overall, they're worthwhile trying, basically. So one thing we get asked about a lot is menopause and weight gain. So is going through menopause causing my weight gain? And as annoying as it is, the answer is no, in that the actual hormone changes of menopause aren't actually known to cause weight gain to happen. But there are a lot of lifestyle changes that happen around that time. You're not sleeping as well. You've got lots of stresses on, you're kind of in that stage of life where you're looking after aging parents, you're looking after children still, kind of in that in-between of just everything is still falling on you. So there's lots of reasons that weight can come on. But one thing that we definitely know does happen is the drop in your estrogen levels. It does make a lot more fat go to the belly, which is cosmetically where we don't like it as well, but also where it's the most biologically active in making you more resistant to insulin, increasing your risk of heart disease, diabetes, and all that. So it is worthwhile doing measurements of your waist and making sure that it is something we're monitoring and being a bit aware of. If you do choose to use HRT, the good thing is that replacing that estrogen does tend to help with redistributing that away from the belly to other places. So one benefit we can get. Weight gain in general, though, it is known to increase the severity of menopausal symptoms. So if you know that you are a little bit overweight, it doesn't have to be a huge amount of weight loss, but even a little bit, say 5% of your starting body weight, can for a lot of people help to reduce the frequency and severity of hot flash symptoms, particularly. And little plug here, if any of you do want any help with that at all, we do have a weight loss and lifestyle clinic that we run at Verve as well, so feel free to have a chat about that. So phytoestrogens, Ashui has already covered a little bit. So there are some products like the red clover, which is a supplemental form. So I'm not talking about those here, I'm talking about the foods that we know are richer in phytoestrogens. So those are things like soy, legumes, alfalfa sprouts, some sprouted legumes that are particularly high, flax seeds, and there's other grains and vegetables along this you can Google if you like. So a lot of the studies that they look at, they found that about a third of women got a significant benefit from including these in a decent quantity in their diet. And we think that's actually because we know that about a third to a half of women actually have the bacteria in their gut that actually converts that to a more potent form. So if you don't have that in your gut, you're not probably going to see those benefits.
But that being said, obviously these foods are really healthy to include in your diet anyway. They're known to have lots of benefits for your heart health, reducing the risk of diabetes, lots of your plant proteins, and lots of your fibre, vitamins, minerals. So I generally do say it's worthwhile kind of considering if you can add a bit more of those sort of things to your diet. So some really easy ways to include it is to try looking at soy milk. Just making sure if you are replacing a dairy milk with soy milk, make sure it is calcium fortified, because obviously bone health is also really important at this time, so you don't want to be ever missing out on the calcium because you're changing to a plant-based milk. Tofu, again, you can actually buy calcium set tofu, so it kind of kills two birds with one stone, making sure you're getting your calcium intake with that, and also getting your soy in there. Interesting, I was doing a bit of research on this recently because I was having a lot of trouble finding calcium set tofu. If anyone's a tofu fan in the room, you don't look as excited as I feel about tofu, but the Evergreen brand that you can get in Woolies of the hard tofu, that is calcium set, so it's a good source of calcium if you're trying to include that. Tempeh is a fermented type of soy that's really good as well. And if you buy just a loaf of bread, you can buy a soy and linseed bread, which is a good source of having both the soy and the linseed in there, so something to consider. And in terms of the quantity that we find is effective, we kind of reference Asian diets, which are just naturally higher in a lot of these foods anyway. So we're looking at kind of the equivalent of having 200 grams of tofu, 100 grams of tempeh, 3 cups of soy milk, 100 grams of soybeans, not all of those, but the equivalent of something like that. We've talked a lot about heart health and how important that becomes around menopause as well. So just really important that you have had that good comprehensive health check done, that you know your cholesterol levels, not just that they're not higher than the lab reference range, but what's the actual ideal numbers? Are you as close as possible to those ideal numbers as you can be? And there's lots we can do diet-wise, exercise-wise to address that. And also knowing your blood pressure, so that's often something that kind of creeps up if we go a long time between checks, so make sure that's all looked at. With the, so if you wanted to look at ways of reducing your cholesterol with diet, I don't know if you've ever been on the Verve Family Doctors website, there's a blog page on there. So if you scroll down, there's a section on cholesterol. I have made a video about dietary things that can help to reduce cholesterol. I also sent out a heart health email recently, probably sick of hearing from me in your emails. Blood sugars as well, another important one to look at because risk of diabetes does keep going up with age. And being more insulin resistant is linked to having more hot flushes as well. But again, if it's in the pre-diabetes stage and that early detection stage, it is very much reversible. So there are things we can talk about to help improve that. The key is, again, just know your numbers. If you're sitting here going, oh, I don't actually know if I'm insulin resistant, then make sure you have a chat to your doctor about having your blood sugars checked and all those things. In general, the advice is to reduce your insulin resistance, make sure you're avoiding your processed foods, try and do all your shopping from the outskirts of the shopping centre where you've got all your whole grains, your whole foods, dairy, basically things that can grow on a farm, that you recognise what they look like. They don't have long lists of ingredients, they don't have numbers and chemicals, is what you're aiming for. And particularly with your carbohydrates, making sure they're not the refined white carbohydrates. So rather than white bread, you want your wholemeal, whole grain breads as much as possible, white rice, brown rice, all those sorts of things. And then when you're setting your meals up, making sure you're not just focusing on a big portion of carbohydrate, add a bit of healthy fat and protein to make sure the sugars kind of get released a bit more slowly rather than giving you big peaks and drops through the day. Bone health, again, we've covered a bit of that. So you want to be aiming for about 1,300 milligrams of calcium per day. The annoying thing with calcium is that we don't actually have any way of knowing if you're eating enough. We can check calcium levels in your blood, but they're actually very tightly controlled because they affect heart muscle contractility and lots of things. So you can have perfectly normal calcium levels and actually be eating nowhere near enough because your body actually leaches it out of your bones to maintain your blood levels. So the only real way of knowing is sitting down, writing out what you eat on an average day and checking does it actually equate to 1,300 milligrams of calcium per day. If it's not, it may be worthwhile having a supplement. There was a little bit of controversy around calcium supplements and whether they actually cause deposition of calcium into arteries, which I don't think is a big concern if you're taking it in lower doses, but the preference is always to get it through diet. So yeah, have a look. The Osteoporosis Australia website is really good. They've got good resources that list out all the common sources of calcium. So you can just sit down and go through all those things, see if there's little tweaks you can make to make sure you're meeting your calcium needs. Vitamin D levels, again, living in Melbourne, you tend to just not get a lot of sunlight and the UV is often very low, that you have need prolonged exposures, particularly in the middle of winter, to get enough vitamin D, so to know your levels, and a supplement's a pretty low risk and low side effects if you need them. Now, exercise. So exercise is the medicine that works for everything. That includes menopause. So specifically for hot flushes, yoga actually does have some evidence that it can help reduce the frequency of it. So it might be something you can have a look at including in your rotation of different exercises that you do. And obviously, we know that all the chronic diseases, kind of the risk is going up around menopause. So exercise helps to reduce the risk of pretty much all of those. And the other thing that happens, not just around menopause, but basically as you age, if you don't do any muscle strengthening exercises, the natural way of things is that your muscles actually break down. So unless you are doing something specifically to retain your muscle mass, it's going to be going down. So we all kind of hear about that 30 minutes of exercise every day is what you need. But we often forget that there's also a recommendation for at least 2 days of the week, 2 non-consecutive days, there should be at least 20 minutes of strength training in there. So it doesn't have to be pumping stuff at the gym if that's not your thing. It can be body weight exercises. You can go on YouTube and look up a 20-minute strengthening exercise, as long as you're doing something that's building a bit of muscle and you can grade it up a little bit when you feel yourself getting stronger. Everything okay?
Yeah.
Overstaying our welcome. So yeah, muscle mass is a really important one to look at. So the other one is flexibility. So again, as you're getting older, it's easy to get a lot of stiffness and joint pains, etc. So including a bit of stretching into your exercise regime is a good idea. All right, now pelvic floor. So I feel like this is something that we get told a lot around childbearing years, when you're breastfeeding, everyone's telling you to do your exercise while you're breastfeeding, but then it also becomes really important around menopause. So it's the one I think that often gets forgotten because you focus on your exercises, but very few of us, I think, remember to do the pelvic floor exercises. Show of hands, has anyone done pelvic floor exercise today? No one. All right, well, we've been sitting for a long time. Let's stand up, let's do a round. We're making you do it, come on.
I started doing it as soon as
Excellent, very good, I'll talk you through. So does everyone know the pelvic floor? You can all sense that it's basically what the contraction that you want to do, as if you were trying to, come on doctors, why are you sitting down? We can do a pelvic floor exercise as well. So your pelvic floor is basically that big sling muscle that sits right underneath your pelvis and it holds all your organs in. So all those things we're talking about, prolapse, etc., that we're trying to prevent, having that really strong muscle there is really important. Interestingly, it's also the muscle that's often involved with sexual pleasure as well. So nice bonus, having strong pelvic floor muscles. So you want to be working on 2 types of movement. So one movement is the one where you hold it up and you can hold it for a prolonged period. So you've got that strength that will hold it for a while. And the other one is the quicker movement. So you want to be able to suddenly be able to contract and be able to let go as well. So that's more useful when you're coughing, sneezing, that sort of thing. Having the ability to quickly switch your pelvic floor on is a really good idea. So try and do a mix of both of those types of exercises. So we'll do just a short set. So we'll start with the holds. So basically you want to contract up and we'll hold for 5 and then we'll let go for 5. And important in between to make sure you are relaxing entirely, because you can do pelvic floor exercises the wrong way and actually give yourself a bit of an overactive pelvic floor if you're also not learning to actually relax it really well in between. All right, so we'll do 5. So contract, 2, 3, 4, 5. I can see it on your faces. So nothing else should be moving. Nothing else should be moving. Yep, it's all internal. And then you relax. And then contract, 2, 3, 4, 5. Relax, 2, 3, 4, 5.
Really hard.
It is. And in the standing, actually, it's the hardest position to do it because you're working directly against gravity. So if you're finding that really difficult, number 1, it's a sign you should start doing these more regularly.
Yeah.
But probably start by doing them lying down.
Get strong quickly.
Yes, you actually notice a difference, so you can tolerate quite a lot.
We were taught to do them when you was sitting in a red light.
Yes, yeah. Red lights, boiling the kettle, just link it to something you're doing all the time. All right, so we've done some of the longer holds. We'll do, say, 15 just normal contractions now. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, might be fatiguing a bit, 11, 12, 13, 14, 15.
Meanwhile.
Yeah. All right, well, consider that your reminder. So start building some of those into your regular exercise regimes. Maybe like if you are someone who is exercising regularly, save that last 30 seconds and you've done your stretches into the pelvic floor as well. It'll feel like a nice break after you've been working out.
You look pretty strange in the gym.
Yeah, that's the thing. If you're doing it right, it shouldn't show anyway. You just look like have a sip of your water, do whatever you want. It's a secret. All right. Environment. Shereen kind of covered a bit of this as well. I feel like it's something that most people have kind of figured out if the hot flushes have been troublesome. But dressing in layers of clothing, have your sleeveless option under everything in case you need to just strip off everything. Try to use breathable fabrics as much as you can. Having a handheld or electric fan particularly next to your bed can be helpful. Lower the room temperature at night if you can. Get your partner to use some extra blankets if they need to, but it's important that you are comfortable. They can manage. Yes, exactly. Keeping a cool pack under the pillow, and then if it's getting really hot, you can switch your pillow over to the cool side. There's some fancy electric blankets you can get with dual controls if you want to look into that. Just drinking iced water, the temperature of your drinks can make a bit of a difference as well. Triggers were already covered, so I won't go into those too much. Omega-3s are an interesting one. The research is probably a bit mixed, and most of the peak bodies are kind of saying it's not really worthwhile. The evidence isn't clear to say it's definitely going to help. But look, honestly, if we're doing it through getting your 2 to 3 serves of oily fish per day, or a couple of tablespoons of foods with your ALA omega-3s like your flax seeds, chia seeds, hemp seeds, it's a good thing to be including in your diet anyway. And there were some studies where some people did get some benefits. So it's one of those things that's probably not going to do you any harm, particularly if you're getting it from a food source or from an official algae supplement. You can do a bit of self-experimentation, see if it makes a difference to you or not.
I can't remember, it was a while ago. I stopped taking omega-3s probably about 4 or 5 years ago because I'd been seeing my doctor and he said exactly that there was no evidence.
Yes.
But I can't remember, it wasn't omega-3, something else came out and they said that it could react with medications, omega-10 or omega-8, I can't remember. So I've just stayed away from it completely.
Sure.
I mean, I eat salmon and fish and stuff.
Yeah. If you're eating your 2 to 3 serves of oily fish per week, you're probably getting your required intake anyway. So there's not a lot of evidence that going beyond that can be helpful. But if you're finding that you're not able to meet that for whatever reason, then perhaps it's worth looking into. Mindfulness, again, there is some early evidence that it can help with hot flushes. And again, going through a really stressful time of life with lots going on, it's just a skill that's really good to be able to build. So there's lots of apps. I like Smiling Minds, it's a good one. Just get into the habit of kind of training your brain to be able to switch off when you want it to. So particularly before bed or after you come home from work, whenever you kind of need a bit of a switch off. It's a good muscle to be able to build to kind of teach your brain to switch off when you'd like it to.
Isn't that what the dog's for?
That's also helpful. A few other complementary therapies I'll go through quickly. Vitamin E, there are a few studies that say that might be helpful to reduce the number of hot flushes per day. Most of the studies were using about 15 milligrams, so if it's something you want to give a go to, you can. Hypnosis does seem to have some evidence as well. And cognitive behavioural therapy, actually done properly with a psychologist, actually has quite good evidence for reducing the frequency of hot flushes and also making them more manageable. I think we've all kind of had that feeling of if you're already feeling stressed out and there's lots going on, if you have a hot flush right in that moment, it feels a lot worse than if you have the exact same hot flush but you're actually sitting relaxed on a beach somewhere. So, helping with all those things. Acupuncture is an interesting one. It does help, but sham acupuncture, where they actually put the acupuncture needles wherever, there's no training or anything, they've just stuck some needles in some random places, works just as well as proper acupuncture by a trained therapist who put it in a good place. So, if that's something you would like to try, there's no real known harms from it and it may give you some benefit. And particularly sleep was the main part that people seem to feel like it helped with. That's everything.